The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back, Sky community. I'm your host, Dr. Carolyn Moyers. I have a special guest with me today, Dr. Cheruba Prabakar. Hi.
Hi. Thank you so much for having me.
Yes, absolutely. So you are the fibroid doc on social media,
Yes.
and you are an OBGYN who is MIGS trained, correct? You do a lot of fibroid surgery.
Yes. So after my OBGYN residency, I did 2 years of extra training in advanced surgical techniques. So I do a lot of robotic and laparoscopic surgery and treat conditions like fibroids, ovarian cysts, endometriosis, such GYN conditions.
Yes. So you are the perfect person. And welcome back, by the way. This is your second time coming back. I'll have to go back and look and find what our first episode was so I can send everyone over there to hear as well. But today we are talking about a form of menopause that doesn't creep in slowly. It slams into your life overnight. I'm talking about surgical menopause, whether you've had your ovaries removed for endometriosis or ovarian cyst or heavy bleeding from fibroids. The fallout can be intense physically, emotionally, and long term. And the worst part is that too many women go through it without ever being offered hormone therapy or even warned of the risk of not replacing what's suddenly missing. So we're going to break it down. What surgical menopause actually is. Are there risks of earlier menopause when you've had surgery but left your ovaries behind? If you've had a hysterectomy but left your ovaries behind, what estrogen deficiency actually does to the body? What does the data tell us about heart, bone, and brain health? And why hormone therapy isn't just symptom relief, but it is protection.
Yes, I love all these. The wheels in my brain are turning rapidly. I love it.
And I just gave you the outline, so let's go.
Great. So I think, one of the things that's really helpful to start with is, when do your ovaries get removed, right? So a lot of women, when they think about a hysterectomy, they either have severe fibroids, they have adenomyosis or endometriosis, and I bring up, okay, maybe hysterectomy is an option. They immediately say, but I don't want to go into menopause. And so first of all, there's just a common misconception that a hysterectomy automatically means taking out your ovaries and putting you into menopause and all of that. So I think it's really helpful just to start by saying a hysterectomy does not mean taking out your ovaries. That is a completely separate procedure. And sometimes they're done together and sometimes they're not. Again, it really depends on your age as the primary factor. So I think it's good to just get clear like that those two always don't go together. But diving into that topic of like, well, can menopause, happen even if you leave your ovaries? Because, you and I both do hysterectomies and we tell patients like, okay, if you're taking out your uterus and you're leaving your ovaries, don't worry, like that's not going to put you into menopause. And, you just take care of the problem, the fibroids, the actual uterus. And that's a simplified way of explaining it. And most often that is the case. They finish surgery. They don't feel any different except of course that their uterus is gone, but hormonally
no more bleeding.
No more bleeding, right? So those symptoms are gone. No more pain, pressure, fibroids, and all of that. But hormonally, they really don't feel any different. But there are a lot of cases where that does happen, and I think we're, as a community of physicians, we're actually not educating our patients enough about, what really happens with blood supply. And one of the things I tell patients when we do a hysterectomy is that, even though we're not taking your ovaries out, it does bring menopause a little bit closer. You will reach menopause on average about a year earlier than you would have otherwise. And the reason for this is there is shared blood supply between the ovary and the uterus. So even though we're not cutting off blood supply to the ovary, its primary blood supply, there are some
Right.
shared collateral blood supply with the uterus. So even when we remove the uterus, some of that blood supply may get temporarily, or rarely permanently, diminished. So even though the ovaries are still functioning, there's often a quick drop in estrogen levels.
Right. And I think also if, a lot of times we're doing the hysterectomy in that perimenopausal phase, right? They're having perimenopausal heavy bleeding and they're just fed up and ready. And we do this hysterectomy and just that we're already like on the cusp, right? We're already starting to have some symptoms.
Right.
And then you have this collateral blood flow that was helping the ovaries and now it's gone. We can start to see those symptoms kind of accelerate for sure.
Yes, that's a really good point. It's not that the surgery just threw you to menopause; you were kind of getting there anyway, and this was the thing that kind of tipped it over. So
Yeah, for sure. So surgical menopause is when both ovaries are removed.
yes, yes. And so surgical menopause is very abrupt. It literally happens overnight, because we are abruptly removing both your ovaries. And sometimes we do this in women who are younger and who have not reached menopause. So some situation that I'm thinking of right now is a patient of mine who has the BRCA gene, for example.
Yes.
Right. And so she's done with having kids and she wants to pretty much reduce her risk of having ovarian cancer because she has this gene. And so she's like, what can I do? And, she wants to remove her ovaries. So that patient, you know, we from before surgery to after surgery, she is now in menopause.
Yeah.
Other patients that
There's
I'm
no gradual decline. It's just
there's
dropping off the cliff.
exactly, which is, has severe symptoms and effects. Other, and we should talk about, how we approach that with patients. Other patients that I'm thinking about are endometriosis. Their ovary is just like gnarly with endometriosis. And I kind of already warned them, okay, we're probably going to have to take that ovary out. And if both ovaries are filled with endometriosis, sometimes we have to take both ovaries out to help them with their other symptoms. So there are situations where, yes, it's super abrupt. And, we hear about how bad menopausal symptoms are and how people are suffering. But this is gradually over time. And then to think for surgery, wow, it is really just overnight. I mean, one can only imagine how you feel.
Yeah, drastic change. So, and I just posted about this yesterday on social media because I got all fired up. A patient had bilateral serous cystadenoma. So she had 10-centimeter cyst on both ovaries, had her ovaries removed, left her uterus behind. She presents to me as a new patient, and it's been 7 months, and nobody has brought
Mm.
up being on hormone therapy. And she's wondering why she feels like a different person altogether. Estrogen, it just isn't optional in this scenario, especially in a 46-year-old woman. I mean, it's protective. And when we remove it suddenly and we don't replace it, the body feels it immediately and often long term. We know that we have increased risk of cognitive decline and mood disorders. The estrogen protects the cardiovascular system, right? So we have more cardiovascular disease, accelerated bone loss and risk of osteoporosis, vaginal atrophy, dryness, painful sex, incontinence, urinary urgency and frequency. And then let's not forget metabolic health, the weight gain, the insulin resistance, the
Right.
fatigue. I mean, come on. So
Yeah.
let's talk about our postoperative approach for these patients. Like, how are we going to replace their hormone therapy?
Yes. So this is a conversation that has to happen before surgery. Um,
Yes.
and right, this is not
What's our
something you
plan?
right. Yes. What's the plan? We're already planning on taking out your ovaries, or there may be a chance that we're going to be taking out your ovaries. And this is what happens to your body when you don't have estrogen, all of the things that you just mentioned. And so we do want to protect your bones and your heart and your brain and everything. So what do we do? And then in my office, we have then a deep conversation about hormone therapy. What are the different types of hormone therapy out there? The patches and the gel and the ring and the pill and all of these things. The patches are what most women use. They're easy, they're safe. And if we're taking out somebody's uterus, then they actually don't need any progesterone. So then we really focus on estrogen therapy. But if they have the uterus and we take out their ovaries, like the patient that you described, then we're talking about estrogen and progesterone. And so, really, just to educate the patient on, okay, what is happening? What am I going to feel? So they don't think that they're crazy, right? So,
Yeah.
what are they going to feel? And then, what are we going to do about it? And oftentimes, I will already give them the patch like before surgery. Go pick up the patch, have it ready, and put it on. We put it on at the hospital, like literally right after surgery.
Yes. So this is something I want to bring up because this happens a lot and in the comments and conversation that happened online, it was okay, well, I was on hormone therapy and then I went to have surgery and my doctor wanted me off of it for months before my surgery and wouldn't let me start it back until months after. Let's talk
Oh,
about that clotting risk and
yes.
I mean, there's no evidence behind those recommendations, number one. So do they need to come off of their hormone therapy in preparation for surgery? And when can they restart it?
So I do not take my patients off of hormone therapy before surgery, even if I'm doing a major surgery like hysterectomy, because first of all, the clotting risk is so low. 5 in 10,000 women over a period of 5 years. Now, of course, being on having surgery puts you at slightly additional risk, but a lot of these surgeries. We're waking up and we're walking, the very same day. And I tell patients, yes, we do want to prevent clots, so we put specialized stocking, like little compression boots during surgery. I tell them to wear compression stockings. Let's get up and walk and be mobile. And a lot of patients are able to do that. And so I don't really think, yes, it's a consideration, but the the downsides of not having hormone therapy during this time. I mean, you already feel like crap because you just had surgery and you're trying to recover. Then you have this whole layer of additional feelings and y- things that were not even experiencing before that you now have to deal with. It's just not fair, and there's just not enough evidence to say that you need to be off of it. Now, in special circumstances, if somebody's on a high dose of oral estrogen, which we rarely even do, then I may say, okay, let's get off of that 2 weeks before, and maybe we switch to something like a patch right after, and then we go back to your oral estrogen 6 weeks after, because that does have a slightly increased risk of clot. But there's so many other estrogen types that we can give patients. So yeah, I that also drives me nuts when people say, oh, my so and so told me that I need to be off of it for 6 weeks before and 6 weeks after. Um, there are specific surgery types like orthopedic surgery. I know where the clotting risk is just a lot more, not so much clot, but just embolism, like,
Mhm,
from fat particles
mhm.
and things like that. So I think they may have a slightly different protocol, but still not 6 weeks before and after. That's just way too much. And I think we as OBGYNs have to also educate other doctors, right? Because they didn't learn this stuff either. And just for patients' well being. But absolutely, I think that is terrible to be taking people off of their hormone
Sure,
therapy.
sure. I mean, they're not gonna take their if they were on oral, they're not gonna take it the day of surgery, but then the next day they can start back, correct? And with our transdermal, like, of course, your patch you're not gonna take your patch off even for surgery, would you?
No, absolutely. I
Yeah.
don't tell anybody to take it off. I mean, the dose is so small, and most of our surgeries are robotic or laparoscopic, and people are getting up and going home the same day, so they're already mobile. And even for open surgery, I mean, patients are walking, the very next day. So it's, I think educating patients on that and, hey, what to look for if there is a clot, like those things are important. I mean, sure, these things can happen, but really, like, how often do we see them? Like, rarely, you know?
Right, right. I know, knock on wood.
Yeah.
It's
Yeah.
it's a bad day if it does.
Yes.
Okay,
Yes.
so I love us, narrowing that down and giving some clarity there because I think that that's a big point of frustration for all of us, and so you're right, as OBGYNs, we really need to be educating, our other colleagues.
And let's talk about from a patient perspective. When should you be concerned about surgical menopause? And what kind of conversations should you be having with your doctor, right? So, obviously, if you're going to remove both your ovaries, you should be concerned about surgical menopause. And if you're older, as in after the latest recommendation says that if we're doing a hysterectomy for someone who's 50 or above, then the recommendation is actually to remove your ovaries, whether you're in menopause or not. This recommendation, the number used to be 65 before, but now it's 50. And so you may not have gone through menopause. Or maybe you're 55 and you're having surgery and you've already gone through menopause, and taking out the ovaries in your case may not really matter. But if you have not gone into menopause, you definitely want to be asking your doctor, what can you expect to feel? What are the symptoms? And also come up with a game plan as to, what type of treatment you're going to be on. And is that something you start immediately after surgery? Do you need a prescription? Do you need to pick something up, bring it with you to the hospital? Sometimes we put on that patch right in the recovery room, right? So these are the questions you want to ask. And then if you're not getting your ovaries removed, maybe you're getting fibroid surgery. Maybe you're getting surgery for endometriosis or an ovarian cyst. These are also surgeries where the blood supply to the ovary can be compromised or reduced. With fibroids, less so, depending on where they are, but certainly with the surgery for ovarian cysts, even if we do not take your ovaries out, we're cutting in there, we're burning, we're taking the cyst out. There's a lot of like activity that goes on that strips away good ovarian tissue, and so even if you are having an ovarian cyst surgery, I would just speak with your doctor ahead of time. Can I expect any changes? Maybe this is not going to put me into full on menopause, but will I have temporarily even some menopausal symptoms? And, sometimes I've treated patients for a few months with a patch. I know they're not really in menopause, but they're having some symptoms because of compromised blood flow. And so it's not a bad idea to even, maybe you're 46 and you can be on it for a few months before kind of your body regulates and gets back into its baseline. So there's a lot of ways to think about it, and I think the bottom line is we need to think about it.
Yeah. I want to come back to your point about removing your ovaries if you're having a hysterectomy over 50, because my understanding is not that it's a universal recommendation, but definitely some shared decision making there, taking into consideration your risk of ovarian cancer. And if you have, because we don't really have effective screening for ovarian cancer, right? So, what a lot of us do is remove the fallopian tubes because we believe that a large portion of ovarian cancer actually originates from the fallopian tubes, and that removing your ovaries, at 50, I would say there's probably less of that risk of, cardiovascular osteoporosis, cognitive decline, et cetera, especially if we're replacing it because we're not talking about a prolonged period of time. But to your point, I think that, shared decision making in regards to your risk is probably the best approach. I don't know. I'd love to hear your thoughts on that.
Yeah. I think like maybe 4 years ago, if I was doing a hysterectomy on somebody who was like 58, I would really strongly encourage them to still keep their ovaries, because even though they reached menopause, that number, was like 65, where they said you were still getting some benefit, like some little uh, estrogen from your ovaries. So I would strongly recommend they keep it if they had no family history and if they had no cysts and other things. Now, again, it's not like, oh, you must take out your ovaries, but I just present to patients the data now that that number is thought to really be 50 because of the lifetime risk of ovarian cancer, even in the absence of family history. We know that it's 1 in 70. And so some patients are like, yeah, I don't want to worry about it. So if you're going in there, just take it out. And I'm happy to put on the patch. I'm so close to menopause anyway. Versus
Yeah,
other
particularly
patients.
if they're already having symptoms, right? They're like,
Exactly.
just let's
Exactly.
not worry
So
with that.
after 50, I mean, by that time, most people are full on in perimenopause. And, if you're operating at 52 or 53, they're already in menopause. So many of them are like, yep, if you're in there, just go ahead and do it. Other patients are very attached to their organs and they're like, I just want to take out what I must take out. So if I really don't need to take out the ovaries, I understand the risk of ovarian cancer, but I still want to keep my ovaries, then sure. We, like you said, we take out the fallopian tubes and we leave the ovaries for them to go into, just natural menopause and hormone therapy if they desire later. So yes, absolutely. We kind of discuss this and I have my patients are sort of 50-50. Some are like, yep, go ahead and do it. And others really don't want to. So, but to your point, I think it's just important to have the conversation. And I think a lot of times women are not having the conversation with their doctor. When I get patients who come to my office, sometimes I'm like, okay, what exactly was your surgery? And they're like, I don't know. Like, I know they took out the uterus, but I don't really know. Do you have your cervix? I don't know. Do you have your ovaries? I don't know. And so we're not, I think from the patient perspective and from the physician perspective, really having that conversation. And as a patient, really knowing what exactly was done, because these have impacts on your health and
Yes,
hormones.
yes. And I think, they feel better and they made the best decision at the time. And then it's easy to not remember, right? So I always like to get the operative report, the pathology
Mhm.
report, like what actually happened. Okay, I want to shift gears and just talk about some of the research. And I've kind of highlighted a couple of those, but I want to talk specifically about the Nurses' Health Study where women under 50 who had their ovaries removed without hormone therapy had higher risk of heart disease and death. And that risk is mitigated by estrogen therapy. So
Yes.
truly, we want to be so mindful of this. And it's so important to have these conversations because we have data that support it. The
Yes.
Women's Health Initiative and the timing hypothesis, which you've brought up as well, when started within 10 years of menopause or right before the age of 60, hormone therapy is associated with the reduced heart disease and mortality. The big
Yes.
mistake, as we all know, is the media panic that happened with the Women's Health Initiative when it was published in, was it 2002 or three? It
Yeah, I think
sometimes
2002.
escapes me.
Yeah.
Yeah, 2002. And the big mistake was this early panic when not really taking into account the significant nuance of hormone therapy. So we know that it is cardioprotective. Um, it improves lipids, it reduces inflammation, it supports vascular tone. So, we have greater arterial aging. So our vessels actually are aging at a more rapid rate without our estrogen. So it's just so important because, this is where, the timing hypothesis before the age of 60, we see those improvements in memory and protection against dementia, right? But if we've been prolonged period and we're starting this in later years, we're not seeing that same benefit. So something for us to just keep into consideration, not only the rapid bone loss that we see our most rapid bone loss at the time in the years around menopause. And if we're making you surgically menopause, so we're going from normal ovarian function to no ovarian function, we are going to see that rapid decline in your bone density as well. So the health impact, it's more than just hot flashes and a dry vagina.
Correct. Yes. Yes. And we know that the number one cause of death in women is cardiovascular disease already, right? So
Right.
and everyone's always afraid of breast cancer and all these other cancers, which rightfully we should do all our screening, but that is actually not the number one killer of women. It's cardiovascular disease, it's the high blood pressure, it's the cholesterol, it's the arterial narrowing that leads to clots and stroke. It's all of those things that you just mentioned. And so it's really, really beneficial to be on hormone therapy and have that extra estrogen for as long as we can. And I think hopefully for anyone who's listening who has been scared of being on hormone therapy, or nervous about it because of all the hype and the media from, if you Google and you go to ChatGPT, right, like on the internet, you can get whatever answer you want, right? So if you've been nervous or scared about it, hopefully after listening to this episode, you're really encouraged to start hormone therapy, especially if you're considering surgery, because again, that there's no gradual weaning off of estrogen there. That is an abrupt cutoff of estrogen, which can probably present like a bigger assault to your cardiovascular system.
Right, sure. Oh, I love it. You're just like wrapping this up with a bow. So, if you are facing surgery, we want you to ask these questions. We want you to find a trained menopause provider, physician like myself or Dr. Prabakar. We don't want the fear of hormone therapy to stop you. We want you to get your facts, advocate for your bone scan, your cardiovascular workup, symptom tracking, because sometimes a hormone therapy regimen or dose may be working for you, but then, 6 months down the road, it's not. And we need to make these adjustments. So it's don't suffer in silence. And if you've had surgical menopause and no one talked to you about your hormones, you're not alone. But now you know, and knowledge is power. And so you can find me at Sky Women's Health in Fort Worth, Texas. I do telehealth in Texas and West Virginia. We will offer you real information, real options, and care that centers you. And you can find Dr. Prabakar in California. Tell them about your practice.
Yes. So I'm right outside San Francisco in the Bay Area, in a town called Lafayette. And I run my own practice where we provide boutique gynecologic care through all phases of life. So whether you are, I think my youngest patient is like 10 and my oldest is like 96. So whatever you need when it comes to GYN health, I really specialize in surgical gynecology, so fibroids, endo, ovarian cysts, fertility, and then also menopause. And so you can find us there and follow me on social media at the Fibroid Doc on Instagram, TikTok, and YouTube.
Fantastic. Thank you so much for sharing your wealth of information. It's always fun to chat. Don't forget to share this episode with a friend or your sister who's going through it. And you can follow me at Dr. Carolyn Moyers on Instagram, and my practice is skywomenshealth.com. Until next week, be well.